is a 61-year-old male. We saw him a couple of weeks ago with a stable angina. The ECG seemed to suggest that the inferior myocardial infarction with Q waves in the inferior leads, akinesia in the inferior wall with a left ventricular ejection fraction of 45. We have a chronically occluded RCA, which we think is supplying a territory without a viability. And then we have a diffusely diseased LAD, as you can see on the screen, with an FFR measurement of 0.82, which means it's not significant. And we have a slightly diffuse diseased first diagonal, which we're not going to treat, which is not that big. And then today we're going to treat this chronically occluded circumflex, as you can see on the screen. We think there might be a microchannel. We're not that sure. We haven't tried it yet. You can see the setup shots. It seems that there might be a small channel. There's a proximal cap. There's a short side branch taken off just above the proximal cap. And there's a bifurcation at the distal cap. So what we're planning today is to do a Antegrade wire escalation and see how far that will take us. It's not suitable for ADR as the distal cap is at a bifurcation. If we get subintimal, we will see whether we'll do a parallel wire technique or just do an investment procedure. That means that we're going to dilate the proximal cap within the subintimal space, but we will see that. We'll start out with Antegrade wire escalation. And Francis, up to now, he has wired the circuit with just a workhorse wire. And he has a microcatheter, which is it's a turnpike spiral there. And then he has a Fielder XTA. And now we're going to see whether we can wire the vessel antegradely. And the patient is loaded with heparin, and we check the ACT every 20 minutes. There's no previous angio on this gentleman, so we don't know the exact route of the circuit, but we think that we can see the microchannel. So it seems that it's pretty straightforward. So Franz is now just bringing the microcatheter with the tip just in to the proximal cap. See if he can redirect the Fielder XTA wire. You see here it goes into the side branches, which is taken off just proximal to the cap. Just changing for a new Fielder XTA because the wire tip has been bent on the other one. So just taking a new one. It brings the microcatheter a little further down, and then it takes some other projections to see whether that suggests that he's within the true lumen. Seems like he's in the right direction, and the microchannel that we saw before seems to be within that one, but there is some resistance. Now it just went in there. Progress with your microcatheter to the bifurcation, and then change probably for just a workhorse wire. To get the microcatheter out, you can either use an extension wire or you can use a trapper. We do both with the trapper to hold the wire while you're retracting the microcatheter. I don't know whether everybody is familiar with this procedure, but you bring back the micro. I don't know whether you can focus on this one. You see you're taking the microcatheter as far back as you still have the wire here. Then you bring down the trapper, which is a balloon that is not in the wire and cannot enter the vessel. It stops approximately 10 centimeters before the distal part of the guiding catheter, and it locks the wire. So when you dilate the balloon, it locks the wire, and then you can just drag out the microcatheter. Always do fluoro when you retract the microcatheter, but now you can see you can just retract the microcatheter, and the wire keeps in place. So we go down with the trapper. I'll take this one. So the next step now is to go bring down a double lumen catheter over this wire that we have, and try to get a wire from the other lumen in the double lumen catheter to bring that one into the other side branch, which is the larger one, in which we want to use for stenting. Which wire do you use for the other vessel? So we will take a CM blue for the main branch, just a workhorse wire. The entry port of the second lumen here will be 1 or 2 millimeters proximal to the proximal marker. So we have to get the microcatheter down so that the wire will enter almost directly into the side branch and not into the CTO. There are different techniques here. You can either bring the wire into the same branch and then retract the double lumen catheter and then retract the wire with the tip of the wire pointing in the direction of the other branch, and then see if it just can slide down into the other branch. Or you can either try to go directly from the double lumen catheter into the side branch. It might be difficult to get into the other branch because there's a 90-degree bend here. So it's beautiful into a side branch here, but still it's the right branch, I would say. Probably the small one taken off right at the bifurcation. Yeah, it is. Yeah. We just do the same once again. Take it back, slide it down with the tip pointing towards it. Yeah, beautiful. Now we're bringing the double lumen catheter back, and then we need the trapper once again. It's a 7-strand catheter, so the trapper should be able to, the guiding catheter should be able to accommodate the trapper and the double lumen catheter. So now the trapper is being brought up, and then, as we did before, just retracting the microcatheter, in this case a double lumen catheter, bringing that one out, and we have the 2 wires in place. And then we're going to work on the distal wire, which is in the main branch. Are you going to do some pre-dilatation before IVUS? Yeah, it's just a 2.5, 30, don't you think? Yes. Yeah. We're going to do a little bit of pre-dilatation before doing the IVUS to see the vessel size and the length of the occlusion. The plan at this point, it might be changed, but the plan at this point is to just stent the with one stent technique into the distal, and of course keep the marginal open, but just one stent. It's to just have a little spin on the spiral to get it down through the CTO, but it seems pretty easy. Take care of the tip of the wire. So out goes now the feeler XJ. Yeah. And then we change for the CM blue. And the patient is completely stable with the blood pressure around 130 of 75 and a heart rate of 60. So now we have the CM blue in place, and we retract the spiral. Still have the trapper in place. Once again, he retracts the microcatheter until he reaches the end of the wire. Bring up the trapper, and then retract the microcatheter while doing fluoro to make sure he's not retracting the wire. So now we have 2 CM blues in place, and the next step will be aluminum. Now we take the trapper out because it's not needed. Maybe not anymore in the procedure, at least not for a while. This is what we're discussing right now. Is that we have the problem we have to overcome in these cases with where you only have ipsilateral collaterals, where you cannot give contrast into the opposite vessel. That means that if you are subintimal and you have made a dissection, then if you give a real fluoro, do a real fluoro with lots of contrast, and you might risk to have a huge dissection. So that's why Frans was so gentle with the contrast in this case, just to make sure that the wires are in the real position. If you were still in doubt, then you could bring down a microcatheter, see if you could aspirate on that one, which it means that you are in a lumen, and then you can give contrast. It's a 2.520, this one. Yeah. How many atmosphere? Just 6 or 8 or yeah. Just a gentle predilatation here, because we will bring down the IVUS in a while to get the real dimensions of the vessel, prox and distal to the bifurcation, and prox and distal to the CTO. We always do IVUS in our CTOs because the distal part of the vessel might be undersized because of a low perfusion pressure for a long time. So that's why we need to see the dimensions of the vessel. We can see some diffuse disease here in the distal part of the vessel. We'll measure the size of the vessel when we've done the pullback. You see here's the second wire coming in. That was from the side branch. So you see the 2 wires, they are around 2 o'clock in the picture. There's not that much calcification. There's between 9 and 11, there's a little bit of calcium, not that much. Here, once again, here at 9 o'clock, you see a little more here when we come into the proximal cap of the occlusion, but still with a thin layer. And here we have some plaque, which is a soft plaque up here. And still a plaque, and now we come into now we are proximal. Is that proximal to the occlusion side? Yeah. This is just ordinary cases, ordinary issues here. We need to do a rerun coming up. Still within the CTO, now at the proximal cap, where you have much more degree of calcium. Now we come into the huge vessel proximal. Some plaque, but we should be able to find a landing zone with less than 50% plaque. Now we come into the left main. That was the LED coming from 12 o'clock. We stop it here because we're not going to stand up to the bifurcation to the left main circ. We're just going to keep the stent within the circ. We probably need to stand all the way down to that side branch, which means that we just need some more predilatation before that one, but we take that one afterwards. So we do some more predilatation of the distal part now. That means that we're going to just go down with the semi-compliant balloon, because there was no calcium at the distal part, just a 2.520, all the way down to where we will land our stent distally. And then we go with a 3.5 non-compliant balloon within the CTO. And then we're going to stent with, we plan to, it was a 62 millimeters in total. So we will go down with a 2.75 38 stent, which will land approximately in the middle of the CTO, and then we'll prolong the stent with probably a 4.0 stent. We saw in the first place that we had some small indentation on the balloon at the proximal cap, so that's why we just and where we can see the calcium on the IVUS, so that's why we want to go down with a 3.5 balloon, a non-compliant balloon here. It's time for an ACT measurement now. So, and then the next step will be the 3.5 bone.
Yes.
Couple of shots from different angles now to see that it's perfectly in all angles. Yeah, we still have. That's yeah, but that's the first. That is the setup. Okay. Okay. Oh yeah. That was the circ. Actually, for the right. Yeah. We're just discussing whether we have any collaterals for the right, which is totally occluded as well, but it doesn't seem like that. So now we have the final shot from here. Yeah. So it's a beautiful result. There's a plaque at the ostium of the circ, but we will not treat that at this moment. If the patient comes back with symptoms, I will do an ischemia test to see whether there's anything in any viability and any ischemia in the territory.